Welcome everyone to the June Health Equity Jam session um, for this year, our last session for this academic year. This is a rescheduled session. We had planned to have it in April, but we had technical problems. In fact, Zoom was down for everyone that day. So I'm so glad we were able to get Dr. Bhattari, our speaker for today, to come back. And we're glad to see all of you, and hopefully more people will join us. But even if they don't, they'll be sorry they missed, because this is going to be an amazing session. So anyway, I'm going to start out as we always do. Well, first of all, any comments on the music? I loved it. Our speaker is on fire. So really looking forward to hearing from her. And so well, I'm going to start out with our usual sort of fun facts and then our more formal introduction. But let's just hear a little bit from our speaker about her choice of music. So what are some of your favorite, who are some of your favorite artists, Dr. Bhattari?
Well, definitely Alicia Keys, of course. Um, and also Beyonce, but I think that's a given. Um, and I'm
So
not embarrassed to say, do
you're a
what?
member of you're a member of the Beehive?
Yes. Oh, certainly. I don't know why one wouldn't be, but also not embarrassed to say Britney Spears was also one of my probably once I moved to the US when I was I think in like second grade all through elementary school. Britney Spears was also someone I really love. But any of the woman empowering type of songs. I have a 4 almost 5 year old now, and this song is something that she just loves to yell and sing at the top of her lungs.
Oh,
So it's a song we sing together. So yeah, she
that's
she
great.
likes it as well.
That is great. She's adorable.
Mhm.
I've had the pleasure of meeting her. So
Mhm.
anyway, so first fun fact about Dr. Bhattrai, she gave away a little bit of it just now, but she said when she came to the US, so any guesses about where she was born and spent the first part of her childhood? You can just feel free to drop them in the chat. Where she was born. That was a good guess. India. Close. Okay. We've got Nepal. We've got the correct answer really quickly, Nepal. So tell us a little bit more about where you hail from, Dr. Bhattrai, and where you landed when you came to the US, which I think is kind of a cool story. Like especially where you landed, because not a lot of people are from there around here.
Yes, yes. Well, so actually when we came, my dad was getting his doctorate and in the University of Bloomington in Indiana, University of Indiana, Bloomington, actually. And so we came to Indiana, and after that, um, my dad was already like in the US. So my mom, my sister, and I came, and then we actually followed him to like some other places, ended up living in actually Virginia for a few years nearby. But then before coming to Baltimore, I have lived in Kansas City for like before coming to Baltimore for the last 10 years of my life. 10 years is probably where I've lived the longest anywhere in my life. Um, and so yeah, Kansas City. And although surprisingly, a couple of our trainees in my division, two of them have come from Kansas City just in the last 2 years, which has been very surprising. So
Yeah. So Kansas City, Missouri, or Kansas City, Kansas?
Missouri for sure. Yeah,
All right. So
yeah,
Casey Mo. Yeah.
yeah.
So
So there's like a territory war, not a territory war, but whether you're Kansas City can include the state of Kansas or the state of Missouri, and so depending on where people are from, they're very explicit about stating that.
oh, okay, interesting. Well, we've got Dr. Felix said her research took her to Kansas City, Missouri. So,
Oh, interesting.
yeah.
Where at?
She's typing in the chat. Oops, she
Oh,
said Kansas City.
Kansas City.
Okay.
Oh,
Oh,
you're also Dr.
there's a Kansas City connection here all of a sudden.
Yes. Well, and of course, Kansas City has been in the Super Bowl for the last 3 years. The last year wasn't the best, but um,
That's true. That's true.
yeah.
Well, you can't win them all, you win some and you win some. So, but anyway, well, okay, and second fun fact, Dr. Bhattari told us about her lovely daughter who sings with her, but she's the mom of more than one kid. So how many guesses about how many she has and whether they're girls, boys, or one of each? So let's see, just a guess in the chat. And then there's like actually a furry family member, so you can guess what kind of a furry creature that might be. But some people on here are not allowed to give the answer, right? I see Chitama, she knows the answers. Yeah. So let's see. Who are the kids and who is the furry animal? So we had K's doing all the guessing today, a boy and a girl. I'll let you answer that, Jackie. Ah, she did get the pet right. So
Mhm.
tell us about your babies and your furry baby.
So I have two human children. One's a 10-month-old, and the other one is, good God, she's gonna be 5 years old, and she is just like a spitting image of me. There's a quote I read the other day amidst the frustrations of parenting, and I read that there's nothing more frustrating than seeing a young version of yourself stand talking back to you. Oh no. And uh yeah, that's exactly what I experienced with her. And then we have the older one of the three kids. The one is a cat, is 8 years old. His name's Diego. And when my husband and I moved to Baltimore, we brought him with us from Kansas City. And he's so near and dear to our hearts. So we call him our firstborn. He rings the doorbell. He likes to go on walks outside with us. Um, and yeah, he's a high maintenance cat. Very high maintenance.
Diego is a daredevil. I mean, Diego like disappeared for a while once, and
Yeah, nine
fortunately was
days.
found. But I remember that time when Diego like went off on an
Oh my
exploration.
God. Yeah, we thought he was dead, and he came back 9 days later, so skinny with fleas. And the minute he came in, he then meowed after he got food to go back out. I was like, no. But
What
yeah,
a character, what a character. Well, we got one final fact before we do the formal introduction, one final fun fact. Dr. Bhattari wanted to be something else other than a researcher and a clinical psychologist. But she didn't end up doing that. So can you guess what her other career aspiration was? Okay, somebody guessed a veterinarian, which is not quite right. Tennis player. I wonder how that came about. Professional dancer. These are all great guesses, but not right. Scuba diver. I think, let's see, author. Who was the closest so far? Dr. Cruz, you were the closest. Yes, you're very warm there, Dr. Cruz. Well, you are right in many ways. Absolutely, absolutely. Bing, bing, bing. Dr. Ali Nurali got it. Dr. Bhattrai wanted to be a singer. So what kind of singing did you do and what kind of singing are you doing these days?
oh, just the highest quality, the most the most important thinking, which is in the shower, which is as much as I get nowadays. And but in elementary school I was in choir. I tried out for every solo part, didn't make it. And I just had a feeling my career wasn't destined for singing. So but yeah, I always wanted to be.
Mm. Well, that's lovely. Well, I can see why you chose Alicia Keys then as one of your favorite artists. But so, well, let's do more of a formal introduction, and then we'll have Dr. Bhattari tell us about her really interesting and important work. So, Jackie Bhattari is she's a Johns Hopkins Center for Health Equity faculty member and an assistant professor in the Department of Physical Medicine and Rehabilitation in the Johns Hopkins School of Medicine. She's a researcher and a clinical psychologist who specializes in multiple sclerosis and related chronic neurologic conditions. And her research focuses on identifying modifiable social and healthcare system factors through both quantitative and qualitative methods that can be used to inform future interventions to promote health equity. So without further ado, Dr. Bhattari, over to you.
Thank you. Thank you, Dr. Cooper. That is always such a fun introduction. I love the introductions in these jam sessions. So hi everyone. Yes, so I'm Jackie Bhattari. I'm an assistant professor here in the School of Medicine, and today I'm going to talk to you about most of what my research entails, and it focuses on individuals with multiple sclerosis, which I know is a relatively uncommon condition, but I've tried to tailor this presentation so that it's as relevant to everyone as possible. So bear with me here, but yeah, so the title of my presentation is Advancing Health Equity in Multiple Sclerosis, Quantifying and Addressing Healthcare and Place-Based Factors. Well, you know what? I haven't shared my screen yet. So I thought everyone was looking at my screen. Can you see the slide?
Yes.
Okay. So let's go to the second slide. So before I begin, I want to just take a minute to acknowledge some people and groups that made it possible for me to do this work and get to where I'm at, including the MS Research Lab within my division, as well as Dr. Cooper and the rest of the Center for Health Equity, where I initially got involved when I was a fellow here in the School of Medicine, as well as the Center for Health Disparity Solutions. So my work is funded by the NIH, the National Institute on Minority Health and Health Disparities. I'm actually at the end of my Career Development Award, which is the end of a honeymoon phase, is how I understand it, as well as the Hopkins Center for Health Disparity Solutions pilot grant, which is has passed, but that's a lot of what the findings are based off of. So just a quick overview. Sorry about that. My screen is glitching. Just a quick overview of what I'll be talking about today, the structure of the presentation. So we'll go over some background info on MS and racial disparities, and then I'll talk about some of the major findings from our work on quantifying disparities, as well as some qualitative findings we've had. And then finally, we'll summarize some of the key themes and conclude with future directions and key takeaways. And then we'll leave some time for question and answer. So let's start with some background. So MS is a chronic neurodegenerative autoimmune disease that affects the central nervous system. including the brain, spinal cord, and the optic nerves. It is the leading cause of disability in working age adults. The exact cause of MS still remains unknown, although it's a combination of environmental um, and genetic factors. Um, what we do know is that MS involves damage to the myelin sheath that insulates the nerve fibers in the central nervous system. And because it affects everything in all these parts of the central nervous system, the symptoms are just um, variable in nature. So this image here shows all the different symptoms that a person with MS can experience. And as you can see, some of these might be visible, but many are invisible, which can make it a very isolating and challenging condition to first get diagnosed with and to live with. And as I said at the beginning of the presentation, MS is not as common of a condition as some other ones we hear about. It affects approximately 3.6 per every 1,000 people in the US. There are, however, some things we've learned about MS just recently that actually make it an important condition for all individuals, especially those working in healthcare, to be aware of. So the national estimate for MS was thought to be about 400,000. But as of 2017, the number almost doubled. And now we know that almost 1 million people with MS are living with the condition in the United States. And in worldwide, it's about 2.9 million. And so that's a pretty big jump from what we used to think. Also, MS was thought to be a disease that impacted predominantly white individuals. And I know when I was learning about MS, I thought that I very much believed that about MS, and whether that was explicitly stated in my coursework or training, or that's just kind of the message I got. That's what I had believed, but more recent evidence shows otherwise. In fact, that the prevalence rate of MS right now, as of most recent research, is was reported to be 4 per every 1,000 people, and then for Black individuals, 3 per every 1,000. The incidence rate, however, is shown to be higher among Black, especially women, compared to white individuals. And that is something that's more surprising and has taken the MS community by surprise. So many new things we're learning about MS, and a lot of things that kind of contradict what we previously believed to be true about the condition. One finding that has been really consistent across time is that regardless of what we believed at the time about the prevalence rate or incidence rate, MS as a disease progresses faster in Black and Hispanic and other minoritized populations compared to their white counterparts. So individuals with MS who are Black or Hispanic are known to progress to disability much faster than white individuals, or get diagnosed at a later rate. And this has been this has been known for a long time in MS. I wanted to highlight this quote to kind of show the importance of the new things we're learning about in MS, and these perceptions, right, of the old knowledge that we have. They kind of stick with us, and our lasting perceptions that we have that then impact how we, as providers, diagnose and treat our patients, but two, also as patients and just individuals out in the community, what we might believe is going on with us, a loved one or a family member. Um, and I think this quote by a Black woman participant, in a research study published in the International Journal for MS Care, really shows this. So she said, "I've always been told it's really kind of a Caucasian disease, and truly that's not true. I'm going along this MS journey, and people are still telling me Black people don't have that. If there's anything that I think maybe misunderstood about the Black culture in MS, I would say people's horizons need to be expanded, that this is an every people's disease now. Um, and when I started my training at Hopkins, I was a fellow and I was getting specialized training in MS. And my interest in research in health equity, social justice has been there for as long as I can remember. And so getting extra training in MS, I really wanted to kind of blend the two fields. And I thought, well, maybe this lens is not as applicable in the MS population because it generally just affects white individuals. And so I dug in deeper into this, and that's not what I found. I found some of like the few articles that existed on the disparities in MS in terms of at least the neurologic disparities that showed the advanced disease, the increased disability, accelerated disease progression. And yet I couldn't find any health equity or like even research quantifying the disparities in the population. And so that is what I ended up pursuing for my research. So I'm going to share just a little bit of background on the racial disparities in MS that we do know now. So although the research has been limited, I think just in like the last 5 to maybe 10 years or so, it has increased quite a bit. So from that research, we know that Black and Hispanic individuals have greater disease severity, more rapid disease progression, and higher risk mortality. Um, Black individuals are also more likely to be switched to higher efficacy therapies, yet this population also comprises approximately 50% of people with MS who experience suboptimal responses. Um, and I should mention the higher efficacy therapies is referring to the treatments for MS are referred to as disease modifying therapies because they modify the disease that is MS. Um, and the therapies can be escalating, right? And so Black individuals, given that the research shows worsening disease at a more rapid rate, higher efficacy therapies, they're more likely to be switched to higher efficacy therapies. Yet the suboptimal responses found in research is really problematic. Um, and then white individuals with MS have the lowest rate of disease progression, um, lowest lowest rates of physical disability, regardless of the type of treatment they were on. Now, I feel like I'm doing a lot of talking about Black and white individuals. And as we all know, the world is not only Black and white. But in MS, the research, disparities research largely focuses on Black and now more recently, more Hispanic individuals and white individuals. And so that's not to negate the impact of MS on other populations, but just that this is the data that we have. The expected role of the social determinants of health, which are the non-medical factors that impact health outcomes, have actually only recently been documented in the literature in the field of MS. Now, in this group, everyone in this audience, I'm sure, is aware of the research on the social determinants of health, at least in general. Um, and the social determinants of health also have an impact on individuals with MS. But like I said, it's only recently that this has been actually like documented and systematically analyzed and reported. Um, so specifically, lower neighborhood socioeconomic status is related to worse neurologic outcomes in MS. Black and Hispanic individuals with MS face greater socioeconomic disadvantages, and that they were more likely than white individuals to live in neighborhoods with greater socioeconomic deprivation, lower educational attainment, be unemployed, and have Medicaid or Medicare versus private insurance. And again, for this audience, I think some of these findings, unfortunately, may not be too surprising, right? But I think what was a big step forward in at least the field of MS is when the group of authors who published on this it explicitly stated that racial disparities in outcomes are better predicted by inequitable social determinants of health versus race and ethnicity, recognizing that these social factors are modifiable areas for intervention to promote equity. Given that there is the genetic component in MS, um, this I think this was a huge step forward. So here's a framework displaying the role of non-medical factors on the disparities of we see in people with MS. And again, like I feel like I'm preaching to the choir here. These this figure, right? Like we've seen these, I mean, in lots of Dr. Cooper's and others' work. And when it was first published in the field of MS, I think it was a big message and a big step forward to working on those modifiable factors that we actually can intervene in. So, in my own research and our research that we've done, we quantified some of the disparities within in the healthcare system and also with respect to place-based factors and the disparities that exist in MS. So the demographic characteristics of overall, the participants included in my pilot and the K23 studies that I previously mentioned showed a pattern that's also worth highlighting. So Black participants were consistently younger than white participants, with 44 to 49 being the age range. This is consistent with the literature in that Black participants are diagnosed with MS earlier, but they might already actually have worse disease burden and disability status at the time of diagnosis. More of the white participants had higher levels of education and more likely to have private insurance and be employed, either for full-time or part-time. Something else important to note is that these participants in my study to date include patients seen here at the Johns Hopkins MS Center and also seen at the Washington University in St. Louis MS Center. Both of these locations are recognized as some of the top tier MS centers for their high quality of care and as just as like leading care centers for MS. The individuals who receive care here also represent a sample of people probably with more resources and higher education. So that's I think that's something important to keep in mind throughout this presentation and also when considering future next steps. So I'll focus on a specific study that I did for my K23 that involved a retrospective chart review of 300 patients, half of which were at Johns Hopkins and half of which were at WashU. So what we did was we examined 4 consecutive clinical encounters that patients had. So the same patient provider dyad, patients with MS and their MS neurologist for their MS related clinical encounters, 4 consecutive ones. And then we examined various aspects of MS care by doing a deep dive on the chart, the medical chart. Our key finding was that there are differences that do exist in the quality of MS care delivered to Black compared to white patients, at least based on the documentation. One of our main findings was that Black patients were less likely to receive the highest level of care, so 31% versus 19%. We looked at the level of care according to billing. So the encounter billing for, let's say, the visit. Um, the highest level of care involves the most complex level of decision making and care, and also involves more time. Um, and so I know, so this represents, right, the kind of visit that they have, which could be representative of the quality of care. In addition, Black patients had less frequent visits and less face-to-face time with their MS clinician. So Black individuals had almost a 2-month higher time gap between their clinical encounters with their MS neurologist. They were also less likely to have important MS disease factors, such as recent relapse or findings from their MRIs discussed, or at least documented in their medical encounters across multiple visits. Now, I should mention, if I haven't already, that relapse in MS, there's the most frequent type of MS is relapsing remitting multiple sclerosis, and that involves MS that relapses. So you have these periods of exacerbations or an increase or presentation of symptoms, um, and then they can go away for a little bit of time before they come back. And then there's progressive MS, which is a type of MS where it progressively gets worse. Um, and so when I say recent relapse, that's, I mean, a recent exacerbation in symptoms. Um, and MRI is one of the primary ways of monitoring MS. And so it's really important when it comes to like discussing the progression of your disease at each visit. And so not having that discussed in a visit is a pretty big deal. So another study we did, we examined the role of place in MS care by linking participant addresses with the area deprivation index. So we had 186 participants total, 80 Black and 106 white, who participated in the study. And the ADI we characterized into tertiles, low, medium, and high. Overall, we found structural determinants appear to affect Black patients differently than white patients in the study. So Black participants were overrepresented in the higher ADI areas. So higher ADI, the higher the ADI, the higher the level of neighborhood deprivation. So Black participants in the high ADI neighborhoods had 6.24 higher chances of being on an MS DMT, which is the treatment for MS. Longer diagnostic delays between symptom onset and official diagnosis. So 3.3 years versus 1.4 years. And then, although not significant, effect size trends that showed greater exacerbations and less likely to have been seen by an MS specialist compared to their PCP or general neurologist. So I want to mention a couple of things in the data. So I know 1.4 compared to 3.3 years may not seem like a huge like numerical difference. However, when it comes to MS, early diagnosis and treatment is really critical to preventing disability and just disease progression. And so this extra little over a year like could mean the difference between someone having to use a wheelchair versus not. So it's no it's definitely clinically significant. One finding that may be a little bit surprising is the significantly higher odds of being on the MS treatment, which is good. It's good that individuals who are more likely to experience worse MS disease are on treatment, right? Yes, and that could mean a couple of different things. I think as results disseminate that the MS it progresses faster among Black individuals. I think providers are starting to kind of focus in on that and starting to prescribe and maybe escalate therapies more frequently. one thing that has come up in discussions about this though, is that are we escalating a little too frequently and maybe not always totally when it's necessary. These escalations and these like high efficacy therapies come with really, really, really significant side effects, including a brain chronic brain infection that could lead to death. So these side effects are pretty significant. So escalating therapies is a pretty big choice to make. Yeah, and then let's see. But I will mention that just because there are higher odds of DMT usage does not mean that the disparities in MS care do not exist, because disparities, we did find some disparities in care, and regardless of what we found in care, the outcomes, the significant disparities in outcomes just persist and have persisted over several decades. And then when it came to findings for white participants, across ADI tertiles, we didn't find any of these variations across when we looked within white individuals across ADI tertiles. So our work also involved a qualitative analysis of patient-reported experiences. With MS care. So we had examined data that was reported or written in the medical record by the provider, right? In the previous study I just discussed. So we wanted to make sure we were also getting the patient side of things. So in this study, we included 20 adults with MS, 10 Black and 10 white. We conducted focus groups and individual interviews and asked about the role of social factors, such as place and race, in their MS care. And participants were selected for either an interview or focus group, depending on their availability, because we wanted to really increase the accessibility of participation, especially with the intention of trying to include individuals who may not have participated in MS research in the past. So based on the thematic analysis, we discovered 4 themes that are listed there: healthcare quality, healthcare literacy, patient-provider communication, and then place and race. Oh, I'll share our overall results, and then I'll share some quotes of some specific examples. So overall, our Black participants reported facing discrimination. Only Black participants discussed the impact of health insurance on their care. This was not a topic that was brought up among the white participants. Only white participants reported living in areas with just a plentiful, abundant providers, that they were very near and lived close to providers for with any specialty that they needed. When asked about race, white participants were more frequently likely to state that race was insignificant, and were also slightly struck by why we asked about race in the context of their care. So the first theme, healthcare quality. So both groups reported positive and negative experiences. I'll share this quote. It started off amazing because I had a good job and good health insurance. But I would say that my MS care has plummeted in that respect because now I don't have the same insurance. And so what I see is the difference of how you're treated as a person with really good insurance and PBOs and everything, and a person with MS who does not have insurance. I see a severe difference in that. Now, I want to mention this is within the context of the United States healthcare system. So, health literacy was another theme. Many of the participants actively engaged in their care and research. As I said, these participants were patients at our center and at WashU. And so they were relatively engaged in care and the research that were conducted by their providers. Black participants did discuss facing financial challenges in accessing care too. The quote here is, I think it's important with MS to be your own advocate. You have to insist that what is wrong is in fact bothering you, that they pay attention and that they sit down. So one thing, the active engagement in their care and research, I think, is so important because MS involves a lot of these invisible symptoms, and the myriad of symptoms that it involves can sometimes be overlooked or misattributed to something else by the patient as well as the provider. Um, and so to hear that patients were able to be more of an advocate for themselves um, was reassuring and great to hear. And this was from a white one of the white female. Oh, I should mention WFH. So we also divided the participants based on income. Um, so we were looking at place and race and part of place. So we looked at the average income level. Um, and we divided by about 50K and divided by low and high income. That was the population and the data that we did have. And so we wanted to make sure that in the focus groups, things, people felt more comfortable to report their experiences. Yeah. And so I guess it makes more sense here that this was a woman, a white woman with a high income based on our groupings to report that she was a big advocate of herself and her care. Patient-provider communication was another theme. Patients reported experiences of medical gaslighting. Actually, I know what the term gaslighting is, but actually probably one of the first times that I heard medical gaslighting used as frequently as I did was when conducting these focus groups and interviews. Patients also appreciated the fact that, my chart patient portals were now available, and so that they were able to communicate with their providers. So this quote, I might say I'm noticing or I'm having these symptoms, and she'll once or twice has told me right off the bat that it's not related to MS. Place was another theme, and there were significant differences in access to care based on one's neighborhood, and health insurance was again only emphasized by the Black participants. So, for example, one quote was, "I feel like I live too far away from what I consider to be good quality health care." And this was from a Black female participant with a high income group. Um, there's a there's a lot of options, so I can see any specialist, any imaging, any lab location fairly easily in the 10, 15, 20-minute drive from where they live. This is a white man from a high income background. That's a lovely quote. I would love to hear that from all my patients. But the other quote, I apologize, the demographics are not listed there. Because I don't have a car, I have to rely on public transportation, which is tricky, can be tricky. It's always planned out in advance, so I can make preparations accordingly. And then race. Black participants reported discrimination in healthcare. Some white participants did acknowledge the potential for discrimination, but did not experience it. Um, so I have met discrimination by being African American, even within my healthcare profession, having MS. People don't want you to see their patients. They don't want to offer you jobs and things like that, thinking that you can't do the work because you have this disorder. It's from a Black woman from the low income group. It doesn't really mean much of anything. My face being white doesn't really mean much of anything. A white woman from the high income group. All right, so conclusion. So let's talk about some themes and implications future research. So I've summarized a wide variety of findings. And I wanted to just take a minute to go over some of the main themes that we identified. So access disparities, unsurprisingly, was definitely a theme. There are geographic, financial, and resource barriers that MS patients, especially Black individuals, experience. Diagnostic delays, longer time between symptom onset and diagnosis for Black patients. Care quality differences, so less comprehensive care or lower levels of care for Black patients. Patient engagement differences, so important for all patients to be engaged in their MS care, just given the nature of the disease. But Black patients experience the adverse impact of engaging in various ways. So adverse impact being things like not having your symptoms be taken seriously, or not, or to start with, not thinking that it's related to MS or that you have MS. Structural determinants, so the neighborhood factors impact care independently of individual factors. And then provider factors. I included this because we didn't really look exactly at how provider factors played a role in our findings, but the first half of the findings I mentioned were reported by the provider. It was documentation by the provider, so in which those provider factors are weaved into that, and that's I think a future step we can take in examining how some of those factors played a role in what we found. There are some limitations I should mention. So one thing I noticed is the lack of statistical significance in some of the findings, um, despite the fact that we do see these effect trends. The sample size I think was too small to detect some of the statistical significance. I think we were underpowered. The goal of these studies was to include, like equally represent both groups of individuals. Um, and so, which started with Black patient participants, um, and then wanted to recruit an equal number of white participants. But in doing that and in our analysis, I think we may have been underpowered. Another thing that may have happened is also that there's been an increase in awareness of MS disparities by clinicians, especially at somewhere like Hopkins. And I do think there's been changes in practice to reflect this, which is a good thing, which is great. And also the fact remains that the disparities in outcomes still do remain. So there's still work to be done. So implications, why should we care? So our findings show us some things I think that, although already known from other patient populations, still now are being recognized and steps are being taken in the field of MS. So disparities in social determinants of health play an important role in in MS, a field that's previously believed to impact largely in white individuals. Um, I think what's been really helpful is leveraging evidence-based information from health disparities research with other populations has allowed us to study some of these disparities without having to break down as many barriers as some of the earlier disparities researchers have had to do. And I think our findings just kind of reemphasize the role that social determinants play in MS, and there's a need for um, greater focus on these factors. And then I think there's key action items that we can take within healthcare and as well as in one's built environment. So, for example, I think one of the limitations that could also act as like a future direction for the case study is when we looked at provider documentation. The limitation is that when we look at documentation, something could have happened that was not documented, right? But what we found was that structure, right, the template of the note that was used, really made it, I think really helped to like follow along with each of the MS symptoms. Now, this was not one of the statistically significant findings, and nor were we able to report it to protect anonymity among providers in both sites, but the templates were different across providers between the sites. And so we did find differences in terms of how comprehensive the care and the symptoms and the assessments that were made. Um, and again, we're in the works of trying to figure out how to report or how to be able to present that while still protecting the anonymity of the people involved. So now as we transition to talking about like future areas and what work there is left to do, I do want to take a minute to recognize the shift that has occurred in the MS field within the last decade. So as of 2014, there was less than 1% of the published research on MS focused on Black or Hispanic individuals. And in recent years, though, this number has really grown. So take a look at the titles in the articles then and now. So even just back in 2010 versus, 2023 and 2024. Does race matter for multiple sclerosis? Or a rapid disease course in African Americans with multiple sclerosis? Excuse me. And now we see titles like multiple sclerosis and Black and Hispanic populations, serving the underserved, social determinants of health and disparate disability accumulation in cohorts of Black, Hispanic, and white patients with multiple sclerosis. I think the shift has come with a shift also in the providers and the researchers who work in the field being more representative of some of the patients that we can serve. So that's the positive thing, right? And I say that like yes, the negative is also coming, so bear with me. So real quick, I want to mention future research, so addressing these MS disparities. So disparities still exist, but MS quality of care may be changing, right? The data that I reported showed that maybe not as many disparities in care exist. So these disparities in outcomes are existing with something, due to something, right? And it's still, I think, within the healthcare system that we can use interventions to prevent or at least decrease some of these disparities. So one thing I said was that a lot of my participants were, I think, well-resourced, probably privileged participants being seen at some of the top tier MS centers in the nation. And this makes me think about who are we not reaching in our research. And so recently I started a study where the exclusion criteria is that the patient cannot be seen at a place for their MS, at a place that's recognized as an MS partner in care by a major national organization in MS, probably the major national MS Society is the name of the organization. So identifying individuals who have not been represented over and over in MS research. And also, how can we better serve those individuals who come into our clinic? So leveraging knowledge from other patient populations and using things like resources, I would say, like patient navigators or, community health workers and social workers. This is not something that has been done in MS, at least not published. There's been one from our group here from the MS Center of using a nurse navigator. They did show more disease monitoring and more medication adherence of the patients who worked with these nurse managers. It was a small sample size, and I think that's a really great area that I'd like to pursue in the future. So the current climate. So also for future research, so I talk about all this progress that has been made in MS, and it certainly has been. And then we think about this, right, in the context of what future research can we do, especially in this current climate. there are challenges that have arose, I think, just within the last year that um, I was not planning for when I talked about my future and next steps. Right. And so um, I summarized some of these current challenges, which includes scrutiny on equity research and funding constraints that come with that, and the language sensitivities that some of us have maybe already had to um, change and adhere to maintain funding. But I think in the future, focusing on alternative funding strategies, whether that's with like industry partnerships or foundation grants, it's probably gonna be the way to go. And strategic framing of the work that we do so that we can do the work. Um, and collaboration between the community and MS organizations and across institutions is also very important. Now, I summarize a lot of these things like I summarize them, but each of these things, they're huge. I mean, for like forming community relationships and partnerships takes time and work and collaborations across institutions and um, like implementing a way to collect patient outcome data within your routine care without taking too much more time and resources. All these things take a lot of time. Um, but they are important considerations now given the current climate. Um, and that brings me to the end of with key takeaways being that in MS, the disparities do exist across the care continuum. And we know the social context is critical. We have known this, and we know that now in MS, this is also a really important area to focus on and intervene in. And then now, given that we know this, and given the current climate in which we are trying to work, we need really strategic approaches that we can so that we can continue doing the work that we do. Um, yeah, and I'm happy to take any questions and answers. And but before I do that, I want to mention that the just this recent discussion, the discussion about the current climate, I feel like doesn't do justice on the actual on the actual current climate. Um, and that was part of me trying to incorporate it as a factor that's going to impact the future work I do in MS and probably for a lot of us in the work that we do. Um, I don't have any answers. I just wanted to say I know it's a consideration, and if anybody else has answers or comments, I'd love to hear them at this point. So thank you. Thank you for your time. Thank you for listening and your attention.
Thank you, Jackie. That was amazing. You're really trailblazing work in your field. So congratulations. I know it was not easy. Doing recruitment, identifying these patients, and I remember when you came to the community advisory board to present like your flyer about your study and trying to identify people who might be willing to participate. And because this is not an extremely common condition, really trying to reach across state lines and, appeal to people, wherever they are. So bravo to you for doing this work, and really shedding light on a condition that really causes so much suffering and disability in people and really shortens the quality of, well, shortens their length of life, but also diminishes quality of life for so many people. So
Yeah.
I wanted to just ask, and I know there might be other people who have questions, so I don't want to dominate the conversation, but I did want to ask you whether you've actually begun any like broader collaborations across different institutions when you think about doing these interventions and trying to be able to document like effectiveness or efficacy. it seems like you are going to need those larger sample sizes. And which groups have you, reached out to, and what organizations have you collaborated with in terms of, being able to sort of bring people together to do this work?
Yeah, so a couple of different groups of people I can think of, but I want to mention Dr. Cooper is my mentor on the K, and it would not have been like joining these two fields would not have been possible without her support. And also the support of like the Center for Health Equity and the CAB. So in across institutions, we have a pretty well established relationship with WashU and the other like centers for excellence with MS, like Centers for Excellence for Multiple Sclerosis. There's a group of them in the United States, and then a few of them across the globe. And so there's a nice strong like community of people to get with partnership. Now I will say that the participants we pull from these centers are probably going to be likely a little more representative to the participants that I presented on today. And so with the other goal of like being able to reach people who have not traditionally or historically been included in MS research, I work with the Minority Research Engagement Partnership Network. And within that, there's a RISE committee, I think. They have their own like community advisory board type of organization that I have recently started getting involved with to see where else we can reach individuals who have not already been engaged with these MS partners in care. As well as we worked with actually a recruitment company who did some recruitment for us using AI and did it online, and we were able to get about 300 participants so far who are getting care outside of these centers. And so this is that kind of effort will take lots of like collaborations and forging kind of new pathways that have not been and may not always be successful. But I think the goal I have is to kind of venture out from what is already being done or who it's already including, to include individuals who have not been historically included in research. So
Good for you. This is really just very admirable. And I'm sure it has relevance to other conditions that might not be as common, but could also disparately affect people from marginalized groups. And, maybe there's not as much attention focused on them. Yeah, I want to uplift the fact that your work has been funded by the National Institute on Minority Health and Health Disparities, which is really, really great. So yeah, I
yeah.
see a comment in the chat. Thanking you for this enlightening talk. I have personal family history with MS, and it's so encouraging to see the growth in research in general and to address disparities with the disease. My cousin dealt with his diagnosis while an active naval officer, and my aunt luckily was a great patient advocate for him while he battled with the VA for his care, an area that is certainly bound to see changes with cuts to the funding. Yeah, really thankful to see such a great advocate in you for this work. That's Christina.
Yeah. Sorry, I know I'm under Center for Health Equity, but just wanted to highlight that this does, really make an impact to real people in my family in particular. He's since passed, but he was very young, not to share too personally on this channel, but he was pretty young when I was pretty young when he was going through his diagnosis, so I don't know too much about his care, but just recall him like doing a lot of his own research and kind of fighting for some experimental care at the time that, wasn't often covered by the VA. So I just really thank you for your work, and, it's really meaningful.
Well, thank you for sharing that. Yeah. The dealing with the diagnosis and the treatment, that is Unfortunately, like a common experience for people with MS, having to do your own research, be your own advocate. And you can imagine, like, if you don't have the social and like the structure and the resources around you to do that, how difficult it would be to get adequate care. And yeah, thank you for sharing that.
Yeah, no, I know exactly what you mean. I can think of several people that I've known over the course of time. One woman who actually was very accomplished, was a lawyer, and developed MS at a pretty young age, and spent most of her life like sort of in a wheelchair, and um, ended up dying pretty young. So I know how, and then another young man I know now who just recently got married. So it's incredible. I just hope they continue to find new treatment modalities, and when they do, that we kind of make sure that everyone who needs them can get access to them.
Yes, yeah.
Yeah.
That's why I think the future of this is using the patient navigation or community health workers and someone to support patients going through the healthcare system, I think would make such a difference, especially like with such a complex condition. This, so
No, I agree. So, well, are there any other questions from other people on the line? We had some people who had to drop off, it looks like, but we did get a good number of people participating. Oh yeah. So have you done any work with family members of patients? That's another potential um, sort of angle, to sort of empower family members to.
I personally haven't more than a couple of like um volunteer events that I participated in, but my very close colleague who also works in MS, she does like both support groups for caregivers for patients with MS, and does a lot of research and like clinical care for caregivers with MS. So, and a lot of like the National MS Society, and there's an organization called Can Do MS. Um,
Mhm.
they have lots of caregiver related resources, events, get-togethers. Uh,
Mhm.
so if that is an area of, in research that, to include in my research in the future, I feel like there's many avenues and people to reach out to for getting that started. So
That's great. There's certainly some advantages to having like a smaller network, especially when you have pretty activated, advocacy groups and things like that. So
yes, yeah. It's unique. It has its ups and downs, and that's definitely one of the ups. Yeah. Yeah.
I know, but you have the opportunity to be a leader. So, and we're here to support you.
Yes, thank you. Have been, and I appreciate that very much. Thank you so much.
Yeah.
Mhm.
Well, folks may be quiet. I see another question from Ali in the chat. Do you see any role of AI for either reduction of disparities in MS care or patient navigation? I feel that AI will integrate into so much so fast, and I wonder if you had any thoughts on where things might head.
Oh, that's a great question, and I have thought of this because in my own clinic, so Hopkins has started using a bridge, the AI, like they record, it's the AI tool to help with patient documentation. So you record the session, and then the AI spits out like a summary and recommendations and everything. Um,
Mhm.
Not always accurate as with any AI, but it has been so helpful to have that tool in terms of documentation. And so in the disparities in MS, I think when we're talking about like templates for notes with patients, right, trying to standardize care and making sure that we deliver the same high quality care to everyone, and also plug in opportunities to provide more support if needed, right, for patients. I think a clinical note template is really an excellent, like feasible way to do that. And I've been thinking about any projects or directions to go for that, but it seems like such a small, like logistical thing that actually can make a huge difference. If you're following along a note in a clinical encounter, you're more likely to like ask about these things if you have to kind of fill it out in your form. Um, so
Yeah.
that's where I've thought about AI. Yeah.
Deidre has a question.
Hi, hi, Jackie. Really great talk. Thank you. And sorry, my connection's been going in and out during the Q&A here, but so if someone else asks this, please forgive me. But I was just struck by what you were talking about, what you were sharing about the delays in the disparities in terms of the delays in diagnosis, and was just thinking about how subtle the symptoms can be of MS, and was just wondering if there's any literature on like what people tend to present, what's the most common presenting symptom. And I, do wonder if both, it sounds like you showed in some of your work, if both patients and the providers like wave them off as not being worth full investigation.
Oh, yes. I mean, definitely. I think you touch on something really important is like a lot of these ambiguous symptoms, whether it's like numbness or imbalance, um, or even some cognitive difficulties. I think these could be attributed to stressors or, oh, it was hot that day. So heat sensitivity is a big thing in MS, right? So, oh, it was really hot. So that's probably just because of that. Or I was extra tired or something like that. And so patients and providers alike are, likely to, I think, dismiss these symptoms. Because well, going to a provider to get those symptoms checked out also come with challenges, right? You got to take off work and get to the appointment, and then you also run the risk of the provider attributing it to something else, or just not getting it taken seriously, as some of the participants I shared with you. So a lot of times what people present with, like optic neuritis is one of the things that are kind of like a little bit of, I would say, maybe hallmark MS symptom, right? If you have optic neuritis or difficulties with your vision, many people I've worked with have said, "Oh, did I have MS?" I have some colleagues who have also had similar experiences, and so and that's like a very identified, like defined symptom, right? And um but what in the research, I think so a lot of the white participants have reported like at time of diagnosis they present with something not as severe, whether that's like imbalance, cognition, numbness, in like an isolated event versus by the time we see some of like the minoritized groups, they are already having difficulty with like walking, like with ambulation, or like it's progressed to a certain extent to where like it requires them going to the emergency room because it's gotten so bad. And so that's also where like the prevention is so important. So there is that discrepancy in like the symptoms that symptom presentation. It takes lots of resources to get diagnosed with MS, especially if your symptoms are largely characterized by some of those like ambiguous ones in nature. That's a really good question.
Yeah, I wonder whether some public education too is really in order. Because my guess is that people are just like going along and attributing their symptoms to something else for a long time and not even realizing or recognizing that it's something they need to seek medical attention for.
Yeah, yeah. Anytime I see a new MS patient, one thing I always ask is like time of diagnosis and time of symptom onset, because most of the time it's different. And most of the time after they're diagnosed, they'll recall another time in their life when they're like, that was probably MS as well.
Yeah. Wow. Well, we look forward to hearing about your next steps and to collaborating with you and supporting your work. And we really appreciate you taking time to share your findings with us, and also to remind us of all the issues that we're all sort of dealing with right now. And I think one of the points that came out of that slide is how much we have in common at this point in time, and how much we can sort of rely on one another and support one another through this time, because there are going to be similar strategies that we'll need to use regardless of like what clinical problem or population we're studying.
Yeah. Yes. Yes. Yes.
So it's good to have you as part of our community. And
Well, I am very fortunate and I feel very lucky to be a part of this community. This community is great.
and I thank all of you who took time to join this afternoon. Oh, it's such a beautiful day. You know, maybe some of the other people who aren't here are playing hooky and sitting outside or something. But anyway, it was wonderful to have you, to see everyone, and I hope everyone has a great summer. And we look forward to seeing you all in the fall in September, and we'll be in touch to let you know like what's coming down the pike. But in the meantime, be safe, get some R&R in, and don't stress out too much. Remember, you've got a whole family of people here to stand tough with you. Okay, thanks everyone.
Thanks, everyone.
Thank you, Jackie.
Thanks.
Great job.